Hi, my name is Selena Matthews. I'm the Director of Hospice Compliance with Alacare Home Health and Hospice. We want to welcome you today as we discuss coordinating hospice care in the nursing home. Our objectives today will be to talk about the hospice philosophy, comfort measures, including symptom and pain control, principles of death and dying, individual responses to death, patient rights, and nutritional considerations at the end of life. Hospice is provided in many settings. The main setting is the patient's home, but we can also provide hospice care in the hospital and in the skilled nursing facility. At times, we've provided hospice in hotel rooms, homeless shelters, wherever the patient is that needs those services. It's based on the understanding that dying is part of the normal life cycle. We promote living until you die. We support the patient, but we also support the surviving family for up to a year after the death. We provide a comprehensive medical assessment and supportive services throughout the care of the patient's life. The philosophy of care, like I said before, dying is part of the normal life cycle. It's a profound individual and family experience. The care focus is on what kind of life do they have left and how can we help improve that quality. The interdisciplinary team is very important to providing the quality of care for that patient. The team includes nurses, social worker, chaplain, and the medical director. Some of the interventions for hospice are to help the patient affirm life. We neither hasten nor postpone the death. The goal of hospice is also to assist the patient and their family members to find purpose in the meaning of life, even in the midst of severe illness. This is achieved through individualized care by a competent staff. To continue goals of care, hospice offers patients the possibility for a positive experience. We help them find meaning and purpose in their life. And we look at reassessment and goal clarification because we all know that your goals may change as death approaches. To become eligible for hospice, the expectation from your physician is that you will pass within the next 6 months. The patient's doctor and the hospice medical director use their best judgment to determine this. The patient chooses to receive hospice care rather than curative care. The patient enrolls in Medicare and or Medicaid approved hospice program. Under hospice services, you are covered by a physician, nurse. We provide DME for the patient, medications related to the terminal illness, home health aid services, social services, spiritual care, volunteer support, and bereavement care. Every so often, you'll have a patient that needs therapy, whether it be physical, occupational, or speech, and that can be provided as appropriate for the patient. Now we'll talk about the coordinated plan of care when a patient is in the nursing home and receiving hospice services. The main thing is hospice maintains professional management of the patient, just as if the patient were living in his or her own home. Now we all know that residents in the nursing home sometimes can trigger quality indicators that are negative for the nursing home. But the hospice team can help validate that those negative outcomes are unavoidable. We know that it's acceptable to have palliative care goals even in the nursing facility. With terminal illness, highest practical functioning could be optimum pain control and control of other symptoms. Communication with each other is very, very important. When there are changes that are needed to the plan of care, hospice needs to be notified. If hospice is the one who identifies that changes are needed, then we need to notify the nursing home. If there's a change in the patient condition or situation, the nursing home and the hospice need to be aware of those changes. As part of the coordinated care plan, we've got to make sure that we reflect the hospice philosophy. We need to make sure that on the orders we've designated the responsible provider. For instance, for wound care, who's going to perform the wound care and when. And we need to change and update that plan of care to meet the patient's needs as they arise. An example of orders on the hospice plan of care that would also be on the nursing home plan of care for wound care would be stage 4 pressure ulcer to coccyx. You need to have exactly how you're going to clean the wound, what you're going to put on the wound, how you're going to cover it, how you will secure the wound, dressing, how often are you going to change it. But the main thing is who is going to be performing this wound care. We all know that nursing homes have their own treatment nurses for wound care. So our nurse has to meet that wound care nurse at least once a week to help perform the wound care, look at the wound, measure the wound, assist in changing the dressing at least once a week. I wanted to go over with you a wound care case study to show what could happen if we don't have a coordinated care plan. We have an 89-year-old female on hospice for adult failure to thrive or malnutrition. She lives in a nursing home. She also has a stage 4 pressure ulcer to the coccyx. The facility nurse is providing wound care every other day, and the hospice nurse is visiting the patient twice a week. On June the 2nd, the hospice nurse met with the facility nurse and discussed the wound measurements. It's important to notice the word discussed. At that time, the wound measured 3 by 4 by 0.5. The agency nurse did not view the wound. They only discussed it. The hospice nurse continued to go twice a week for the next month, but they failed to assess and measure the wound. A month later, on July 3rd, the hospice nurse made a visit at the same time the facility nurse was providing wound care. The wound now measured 6 by 5 by 1, with eschar present. The facility nurse stated the eschar started about 2 weeks ago and that new wound care was started. We all know it takes participation from both parties to provide quality wound care. In this case study, what do you think went wrong? Well, first of all, the hospice nurse, they didn't assess the wound at least once a week, and they didn't measure or at least observe the wound care nurse while they measured the wound. The nursing home didn't notify hospice of change in condition, and they also didn't notify hospice when the plan of care was altered. One thing to note here, though, is that the hospice nurse should always look at the patient's chart each time they visit the patient. So when the plan of care was altered 2 weeks ago, the hospice nurse should have recognized that in the chart. Moving on to patient rights. The rights of a hospice patient include privacy. Just in any other setting, confidentiality is very important as far as the patient's concerned. Information about their health, their social status, financial circumstances. They have a right to spend private time with family, caregivers, and friends. And the financial rights, they have a right to be informed of charges not covered by Medicare or by Medicaid and charges for which the patient is liable. The patient also has the right to be treated with dignity and respect. Care and quality of life measures are most effective when the patient's lifestyle is maintained and the philosophy of his or her own life is respected. Hospice has a respect for ethnicity, cultural orientation, social and sexual preferences, and varied family structures. Individual patients' and families' needs vary depending on values, cultural orientation, personal characteristics, and the environment. Hospice caregivers need to be non-judgmental and provide unconditional positive regard when caring for terminal patients, treating each and every patient and family as unique. The hospice patient should be a part of the decision-making process. They should know what kind of care is going to be furnished and the disciplines involved in that care and how often they'll see that discipline. For instance, they need to know that they'll see their social worker once a month or twice a month, whatever is needed for that patient. They should be able to participate in their plan of care. They should be able to refuse services if they want to. And they should also be able to choose their hospice provider. We all know that if you have a terminal illness, it's going to involve many decisions on the part of the patient and family. Open communication and effective interaction is maintained between the patient, family, and hospice caregivers, including the nursing home staff. As the care providers, our role as hospice and the nursing home staff is to provide the patient and family with information and an array of choices. With open communication, informed and autonomous decisions between the patient and family are often achieved. Decisions that are made as a family unit are also less likely to result in a conflict at later time, thus assuring the patient's wishes are met. The patient has a right to receive the highest quality of care available. They have a right to receive all necessary palliative and supportive services to promote the physical, psychological, social, and spiritual well-being. They should also be informed of what to do in case of emergency. One thing important to note here is that hospice is available 24 hours a day, 7 days a week, including nights, weekends, and holidays. The nursing home should feel free to contact hospice for any changes in the plan of care. As a matter of fact, they should always contact us for changes in the plan of care or changes in the patient condition, and a visit will be made as soon as possible. And again, to reiterate, the patient, caregiver, or the nursing home staff should notify hospice in advance of any treatment, testing, or medications that are not provided or arranged by the hospice. Notify us for changes in condition, whether it be pain, nausea, vomiting, constipation, diarrhea, any kind of symptom that is out of control. But again, just any change in that condition. They also have responsibility to follow the hospice plan of care and work with us as a partner, and notify the hospice of the patient death. Once the patient passes, whether it be nighttime, weekends, daytime, the hospice nurse should attend the death. To sum up patient rights, on admission to hospice, the patients are given a copy of the patient rights and responsibilities, and a copy is left in their folder in their room. Now let's talk about comfort approaches for pain and symptom management. There are many physical and psychological symptoms common at the end of life. A few key principles of symptom management show that uncontrolled symptoms create suffering and distress. We need to be diligent about our assessment and evaluation of the patient's symptoms and provide interventions as soon as possible. But the main thing is we need to work as a team to get this patient taken care of. We all know that uncontrolled pain and symptoms can directly impact both the patient and their family's physical, social, and spiritual well-being. Failure to assess and address any component can result in profound consequences for the patient and family. Some of the consequences may include, but are not limited to, the patient having a poor appetite, unable to sleep, decreased quality of life, diminished enjoyment, anxiety, loss of control and feeling useless, poor compliance with the plan of care, and agitation and anger. Now let's review and discuss symptoms common at the end of life. You can refer to your handouts for the common medications that we use for some of the physical symptoms, but just know that each individual is unique and there may be a lot of other medications that we might use. But one thing I want to point out is under shortness of breath, a lot of times we'll use opioids, and the choice is a lot of times morphine, the liquid morphine. And this just relaxes the lungs and allows more air to get in, and it's proven very effective for shortness of breath. We also like to use benzodiazepines to help the shortness of breath. It helps calm the patient, and again, they can get more air in. So we won't go into detail about everything here. I think most of the medications you're probably familiar with. Again, on the next page, and as we all know, there's always symptoms that are there that we might not even address here. But again, that's why hospice is available to you 24 hours a day, 7 days a week, to help see what the patient needs to control their symptoms. Now, as we all know in hospice, pain is probably the major symptom that we have to take care of. And so we want to talk about pain in general today. Pain management is the study and practice of blending tools, techniques, and principles to reduce the pain and suffering. It also emphasizes an interdisciplinary approach, which means hospice, they should get together as a team with their medical director and with a nursing home to decide what is best for that patient, what's worked in the past, what hasn't worked in the past, so they'll know where to begin. We also want to point out that pain is whatever the person says it is. It's experienced whenever they say that they are experiencing it. So we don't need to be judgmental about the patient. To treat pain, it is very important to understand there are also psychological, social, and spiritual aspects of pain, and an interdisciplinary approach is used in hospice to help deal with all of those aspects of pain. When we talk about the dimensions of pain, a lot of times we'll hear the patient say, "I'm just hurting all over. I have pain all over." This generally refers to total pain or some type of existential distress. The interdisciplinary team will assess the patient's emotional state for depression, fear, anxiety, or hopelessness. As seen previously on another slide when we talked about untreated symptoms that have consequences, the next two slides just show some symptoms that will be a result of untreated pain. The main thing here is the suicidal ideation. It's very important for us to recognize signs and symptoms of a patient who might have a suicidal ideation and make sure that we get them the appropriate help that they need. We should always collaborate with the patient when it comes to their pain control. Pain is a personal and subjective experience, and whenever the patient can self-report, that should be the main source of how we know about their pain. If they can't self-report, then a family member or caregiver should be able to tell us what they think their pain is, and that caregiver may be the nursing home staff. A multidimensional assessment should include signs and symptoms of physical, psychosocial, and spiritual pain and suffering. The resident should be able to choose their own goal for pain, if and when appropriate. And it's the hospice responsibility to provide information about pain management and help support the goals that the patient has set. The intervention should treat all facets of pain. Ongoing assessment, adjustments, and changes to the plan of care to provide optimal comfort for the patient is of utmost importance. Managing pain in hospice usually begins with non-opioids and then eventually leads to opioids. We also use medications that can help enhance the effects of non-opioid or opioid use. One thing that we use is the WHO ladder. It was developed by the World Health Organization in 1986, and it's a guide to managing pain associated with a serious illness. Step 1 is for mild pain, non-opioids, which is the aspirins, acetaminophen, ibuprofens that you're used to seeing. Step 2 is the mild opioids such as Norco, and step 3 is for strong opioids such as morphine. And by the clock means if you've got a patient having a lot of pain, you probably want to start a 12-hour medication so that they've always got the pain medicine in their system, and then they can have a PRN dose for breakthrough pain. This next slide is just a copy of the WHO ladder and what it looks like. It's very important that the nursing home staff notify the hospice provider immediately if the patient has new pain or pain that is worse or not responding to previous interventions. New symptoms, symptoms that are worse, or symptoms that are not responding to interventions are also important. Now we'll talk about nutrition at the end of life. We all know that food is central to life. We have to have food. It's very important for us where we live. It's the center of our celebrations. Families are always concerned that the patient will starve to death. Our society is one where nutrition and hydration are equated with caring. So sometimes the families feel like if they withhold food or drink, that the patient will feel like that they're not cared for. But when our bodies are sick enough, they can't overcome weight loss and malnutrition, regardless of what you try. You could even try the PEG tubes, G tubes, IVs. No matter what you try with the patient at the end of life, it's just going to cause more discomfort for them. Nutrition support alone will not reverse or cure a disease or injury. We have to teach the patient and family that at the end of life, our bodies change. It's a time of change that it's hard to recognize as a family member, but a lot of times the patient, they know and they are okay with no more food or water. Our bodies actually serve as a protective function, and the brain decreases the appetite as part of the dying process. If you put food in a patient's stomach that's dying, it's probably going to make them nauseated, very uncomfortable. It can increase their pain, so we don't want to do that for a patient. So the main thing is that you teach the family what to expect in the dying patient. A lot of times with nutrition at the end of life, you'll see anorexia, which can be reversible. And then in most cases, you'll see cachexia. It occurs most often in cancer and non-cancerous diseases. But it's the breakdown of fat and muscle, and in advanced disease, you won't see it reverse. It's a metabolic abnormality, and the patients a lot of times will just look skeletal. Some interventions for nutrition could include, the main thing is no dietary restrictions. If they're truly at the end of their life, we need to let them eat what they want to eat, what tastes good to them. If they want to moisten their food with a lot of gravy, butter, sauce, go ahead and give it to them. Of course, make sure the doctor's okay with it. But the main thing is that we provide them what they need to make them feel better. Some more interventions, but they have to do with medications, could include Megace, alcohol, Decadron, Remeron, Zyprexa, and Periactin. One of the most important things you can do for the patient and family is talk to that patient in the very beginning. Find out what their goals are. What do they want to happen when they get near the end of life? Do they want a feeding tube? Are they okay with not eating or drinking and not having an IV? Make sure that they have a clear goal and that it's documented, that the family understands it, and the hospice team and the nursing home team understand what that patient wants. One thing we want to touch on today is IV fluids. One of the pros for doing IV hydration is that it gives the patient appearance that we're doing something. But there are a lot of cons to giving IV fluids. It may prolong the dying process, it may worsen their symptoms, and it does not improve symptoms of a dry mouth. Some of the pros of dehydration could be the patient gets more sleepy, they have a decrease in their GI fluid, which causes a decrease in nausea and vomiting. They have an increase in opioid peptide production, which results in natural occurring analgesia, decreased gastric stimulation, resulting in lack of hunger, and it also decreases their lung secretions by being dehydrated. Some of the cons of dehydration include dry mouth, but you can use ice chips and perform frequent mouth care for that. The feeding a patient is symbolic of nurturing. So again, you've got to talk to that family about what the patient wants. And it also gives the appearance of abandoning the patient. So making sure you educate the family on end-of-life nutrition is very, very important. As you're talking to the patient and their family about what they want at the end of life, you have to discuss tube feeding. So many people think that they're just great and wonderful, but studies show that they do not reduce incidence of aspiration pneumonia in advanced disease. They do not improve survival in advanced disease, and they do not demonstrate improved quality of life. Some words of wisdom for nutrition at the end of life. We've got to make sure they understand that the declining appetite is a normal and expected part of the dying process. We always want to encourage caregivers to maintain oral hydration, good mouth care, and nutrition as long as possible, providing the kind of food that they want to eat, so on and so forth. We also want to maintain comfort and avoid unnecessary and distressing procedures. Our goal is to improve the quality of life. To conclude the presentation, we do want to talk about two paths to death. For most patients, the dying process is a natural slowing down of physical and mental processes. The usual road entails sedation and lethargy, and eventually a comatose state and death. But for some patients, unfortunately, the road is more difficult, including confusion and restlessness, delirium, seizures, and then they become semi-comatose, comatose, and then they pass. Although we never know the road that will be taken, hospice has an expertise that can help with each individual need. Again, to recap, we provide services for symptom control, psychological intervention, psychosocial intervention, spiritual care, resident and family support, bereavement for family, and for nursing home staff. Residents who meet criteria for hospice and choose palliation over aggressive treatment would benefit from a partnership between hospice and the nursing facility. Together, we can provide a better end-of-life experience for the patient and the family. For future questions or suggestions about our care and teamwork, please contact your local Alacare office.